All right, we are live now for our webinar. We've got a lot of people that are going to be logging in and joining. We're going to be going over the hospice proposed rule here in just a second. Give everybody a few minutes to get logged in, and then Greg will take us away.
Absolutely, and just so everybody knows, as is most common with these webinars, everybody's on mute. If you've got any questions, go ahead and pop them in through the Zoom question and answer section there. If we have time at the end, we'll handle those. If not, they'll be included in the PowerPoint deck that we'll send out after the presentation. And again, do feel free to ask any questions you might have. We just launched a poll for you so that you can give us an idea of where you stand relative to this new rule. And we've got quite a few folks that are responding. Somewhat familiar seems to be winning the race. But we'll get started here in a moment, just as soon as we let a few more folks log on. All righty, looks like most everybody is saying they're somewhat familiar. We've got about 1/5 of you that say you're really familiar, another 1/5 that says you're not familiar, and a couple say, what's the proposed rule? I like it, I like it. All right, well, that gives us a good idea. We'll go ahead and take that poll off the screen. And okay. Well, you know, I think we've given it enough time, got a whole lot to cover today, so we're going to go ahead and get started. I want to briefly introduce the folks that are here with us today. We're very honored to have all of you signed up for this webinar and showing up to listen to what we have to present today. But KanTime and Waystar are co-hosting this presentation for you on the 2022 Hospice Proposed Rule. My name is Greg Lotz. I've been with KanTime for about 5 years. And we also have Kristen Duell on the line. She's our Executive Vice President. Thrilled to have her with us today. Lindsay Cobb is the Product Marketing Director at Waystar. And of course, the belle of the ball is Melinda Gabori. She is going to do most of the presentation today and is the resource that's provided this information for us. She's got more than 29 years in home care, has over 20 years of executive speaking and educational experience, including extensive day-to-day interaction with home care and hospice professionals. She routinely conducts home care and hospice reimbursement workshops and speaks at state association meetings throughout the country. Melinda has profound experience in Medicare PDGM training, billing, collections, case mix calculations, chart reviews, and due diligence, UPIC, RA, ADR, and TPE appeals with all Medicare MACs have become the forefront of Melinda's current impact on the industry. She's currently serving on the NAC HHFMA Advisory Board and Work Group and is treasurer on the Home Care Association of Florida Board of Directors. Melinda is also the author of the Home Health Oasis Guide to Oasis D1, clearly well credentialed in both hospice and home health care and an excellent resource for our presentation today. Next slide, please. KanTime is an enterprise EMR software that handles multiple service lines, including hospice, home health, home care, pediatrics, self-direction services. If it falls under post-acute side of the industry, then we solve the complexities with our configurable solution. We serve over 912,000 patients and 210,000 users across 42 states and growing every day. Next slide. Specifically for hospice, one thing I want to bring to your attention is KanTime's triangle of care. We can eliminate your IDT prep time with the way KanTime Hospice works. The plan of care drives, the assessment drives the plan of care. The plan of care then drives required IDT documentation in the follow-up visit notes, which automatically pushes those to the IDT note. So your IDT meetings can be a much more effective use of time without days of research and copy and paste. All right, without further ado, I want to shift it over to Melinda and let her take control the presentation from here. We have a lot to cover today. Remember, if you have questions, please go ahead and type them in the area there on the Zoom bar. Melinda, you have it.
Thanks so much, everyone, and welcome. We do have a ton of information to cover today, so we're going to jump right in. This proposed rule was quite large as far as content's concerned, and has a lot of things in it that you, as hospices out there trying to make it day to day, really need to become familiar with, and really, we hope, will provide comments and feedback to CMS, with the deadline for the comments being mid-June. You still have plenty of time to review the content of this proposed rule and offer comments, which can be done online in just a matter of minutes. It's not a complicated thing that you have to try to figure out how to get there and go to the post office and all that. You can submit your comments online, and they are very, very much needed. This is a recap, this screen, of the content of the proposed rule, and we're going to talk about pretty much every one of those, so I'm not going to read through that list for you. The financial impact of this proposed rule is estimated to be $530 million in increased payments to hospices, which really is reflective of a 2.3% increase in hospice payments and in the hospice cap. The wage index changes that occurred last year as a result of them revamping the case mix weights in the 2021 fiscal year, which we are in now. If your CBSA area changed to be rural from non-rural before, you were capped at a maximum of a 5% decrease in your wage index in fiscal year 2021. That being the case, that was only good for 1 year. So whatever the change in your wage index was to be as a result of you being changed from urban to rural now in your wage index calculation, that full impact of being changed to a rural provider will hit in fiscal year 2022. There will not be a 5% maximum hit on those wage index decreases. This is the rate changes that have been proposed for 2022. We expect the final rule, just so you know, to be out the first week of August following the comment period ending, and then CMS having time to review the comments and make final decisions. Typically, as far as the rates are concerned, there is typically very little change between proposed and final rules, and sometimes no changes at all. Just to keep that in mind. So if you do meet the quality data reporting requirements, these will be your rates for 2022, and you see the different levels of care there and the increases, which equate again to 2.3% increases. If you do not submit the required quality data, and we're going to talk about the components of quality data submission in a few minutes, because they're talking about changing that information and making it publicly displayed in this proposed rule. So we'll talk about the content of what quality data submission means in a few moments. But if you do not meet those requirements, the screen now reflects the rates that you would receive as a result of not meeting the quality reporting requirements. This screen shows the 2.3% increase in the hospice cap. As you see, it's $31,389.66. If you have question at all about how to monitor the hospice cap, or how that hospice cap technically applies to your hospice, how it's calculated, you need to make sure that you investigate that farther. From a very, very, very high bird's eye view, my main comment to you today is that if you don't know anything about the cap, but you have a significant volume of long-term patients in your hospice, you need to seek guidance on the hospice cap as soon as possible. because hospices that have significant numbers of long-term patients are typically the ones that get hit with cap issues. And in a nutshell, if your overall per patient amounts exceed the 31,000 per in any given year, you have to pay back the difference. So you need to make sure that you are up to par with what that really means. So they are talking about in this proposed rule, rebasing and revising the labor shares that are used in the calculation of your payments. So the current labor shares that are in place were put in place, believe it or not, in 1984, based on information at the time for the inpatient and for the continuous home care and routine home care rates at 68.71%. They were using home health agency wage and labor portions at that time. For inpatient respite and GIP, they were using the skilled nursing facility information to establish labor rates. So for those of you who are not sure why this is even applicable, the labor share portion of the calculation of your payment means that the base rate is taken that we saw a few minutes ago on the previous screens, multiplied by the labor rate, as you see here for continuous and routine at 68.71%. The result of that is where your wage index is applied. The balance of almost 32% of that base rate is not adjusted at all, but 68.71% of it, the wage index is applied to that. And so they're talking about rebasing those rates to be more current. They would derive the information used from direct patient care salaries and contract labor costs, direct patient care benefit costs, other patient care salaries, and overhead benefit costs. The total compensation cost for each hospice provider would then be calculated by summing the cost of the 5 components for each level of care. And so in order for them to do this, they're going to have to use your annual Medicare cost reports. Some of you probably just shivered to your bone, meaning it makes you really nervous to think that they would actually set our rates in any way or form in using our cost reports, because your cost reports aren't prepared well. And I'm not saying that's true for everyone that's on this call today, but I can tell you that for the most part, anytime that cost report data is assembled and used in calculations, they have to eliminate 25 to 35% of cost reports because they are not prepared based within the regulatory requirements of cost report preparation. So if you had a thought of concern regarding your cost report being handled inappropriately, you really need to seek guidance. And I'm not trying to get your business, because we don't do cost reports. But if you need assistance in finding someone that can do a cost report and do it the way it should be done, so that in future years, we are all impacted positively by that, I would be happy to assist. So in the current calculations that they are proposing, continuous home care, as you see on the screen, would go from using a labor portion of 68.71% to 74%. Routine home care would go from 68 to 64. You see the other numbers. So what does this mean, actually? So what this means is you would need to look at your wage indexes that you currently have in place, which could be 1.0 or greater, or could be much less than 1.0, meaning less than 100% to be applied. And so if the wage index or the labor share, on the screen is going to increase, as in the continuous home care going from 68 to 74, if your wage index is 1.0 or higher, you want that number to increase, because you want more of the base rate to be applied. And if your wage index is less than 1.0, you are not going to want the routine home care situation as you see it on the screen. Okay, I think I said that backwards. I did. So if your wage index is 1.0 or greater, no, I said it right. So you're going to want a greater portion of the base rate to be applied to that 1.0 or greater. I did say that right. Okay, so the routine home care, you're going to want you're going to be concerned if the labor portion is decreasing if you have a high wage index. So hopefully that makes sense. So you need to look at those labor portions, how they're currently being applied as far as your wage index is concerned. And if it is going to negatively impact you, you definitely need to make sure that you comment, and your comments having real examples as to how that would financially affect you definitely needs to be heard. So they are looking at utilization trends through the hospice data over the past few years. I believe that most of the information that they have presented, that we're going to look at some of it, came from fiscal year 2016 through 2019. And so we don't have time today to go through each and every one of these trends and look specifically at them, but I have given them to you all in one place, so you don't have to technically go to the proposed rule itself and try to dig them out. So on this one in particular, they have given us the diagnoses that are considered to be the top 20 principal diagnoses. And this one is specifically for fiscal year 2019. It's giving you the primary diagnosis on the left, and then the percentage of all reported primary diagnosis on the far right, with the number of beneficiaries in the middle. So what do you need to do about this, or what do you need to look at or consider here? And so a lot of the medical review post-payment reviews, which are the only ones that can happen right now, when we look at those post-payment reviews and what's being pulled to be reviewed by UPIC auditors, SMRC auditors, by the Medicare MACs themselves, we are seeing a huge influx of those post-payment reviews be specifically focused on non-cancer diagnosis with patients with a long length of stay. And I think you probably could understand that being the case when you see that the top diagnoses on this list are not cancer diagnosis. And so this shows you that the trends that they see and that they monitor really do mean something to them as far as what they're allowing in the form of post-payment reviews. This is average lengths of stay. This is pretty scary for some of you, I'm sure, because this shows that average length of stays for an election period, which means from the time the patient elects the hospice benefit until the patient is discharged or dies. And as you see, that trend has increased, the average number of days from 2016 to 2019, and the average lifetime length of stay has also increased over the course of that same time. And so when I said that some of you probably are nervous by this, is because if your hospice overall average length of stay is higher than these numbers, you really probably should have reason for concern, especially when it comes to medical review, because lengths of stay is one of the big numbers that they look at. This is average length of stay by specific diagnosis categories. So cancer, as you can see, is all the cancers are lumped into one category, et cetera, which I thought this was some really good information. And as you see, the average length of stay by the individual diagnosis is listed there as well. And so if you do have a lot of patients in the Alzheimer's category and their average length of stay is greater than 169 days and per election a greater than 126, you really should be concerned that you might be on a medical review path. These are Medicare payments for non-hospice Medicare Part A and B items while the patient is on a hospice election. So one of the big issues in hospice of late, and when I say of late, I mean in the last 5+ years forward to today, has been since the OIG investigated the hospice situation a few years ago, including that they were looking at what Medicare Part D was paying in the form of the drug benefit for patients who were currently in a hospice election, and they were blown away, which means Medicare Part D were paying for millions and millions of dollars of drugs for patients who were currently on the hospice benefit. As a result of that audit a few years ago, hospice is now required to report all diagnoses that specifically affect the patient's terminal prognosis. And if the diagnosis is listed basically in your chart, you're going to be responsible for all the care surrounding that. So this is them looking at the dollars that are being spent on hospice patients for non-hospice items, services, and drugs. This data, coupled with the data from the Medicare Part D program, is the reason why we had to start issuing the election statement addendum that we're going to touch on in a moment. That election statement addendum, including that you provide to the patient a list of items, services, and drugs, and justification, both in clinical language that they can understand, as well as Medicare regulatory language to explain why you believe those items, services, and drugs are not considered related to the terminal condition and related conditions. I'm convinced that because of all this data and the data I mentioned a moment ago from the OIG, is the reason why we have to do those addendums, and that Medicare believes that as you are trying to justify certain things not being related to the terminal illness and related conditions, you're not going to be able to do it for the most part. In other words, you're going to realize more than ever before that there are things you should be covering that you have not been covering in the past. So in relation to all of those statistics I just showed you, CMS is seeking comment from providers on that data that they have presented in the proposed rule, most of which I just gave you, and looking at some specific things like skilled visits in the last week of life, et cetera. And they're looking for us to comment on those things, and we'll use them in future rulemaking. This next item is the election statement addendum. We have been seeking clarification for many things related to this addendum since its implementation, actually since before its implementation last year. And these are some of the things that are related to that. They currently, with this addendum, you're required to provide it to the patient within the 5-day window of the comprehensive assessment if they request it at the point of election. If they request it after care has begun, so not at the point of election, but after that, you're currently required to provide it in 72 hours. The proposed rule is proposing that if it is requested in the 5-day window of the comprehensive assessment, that you still have a full 5 days to respond instead of the 3 days that the language currently has in it. That is also proposing that they change the current language from the 72 hours for you to provide it to the patient if they request it after care has begun to actually 3 days instead of 72 hours. And if you really think about it, some people would say, well, why does that matter? It matters because if they request it at 5 p.m., you only have 72 hours to 5 p.m., exactly 72 hours later, when 3 days would be 3 days before midnight on the third day. So hopefully that language will go through. This is just a little example of how that would work. They have also addressed somewhat the questions that we have regarding the fact that you are required to get a signature from the patient or caregiver that has requested the addendum. They are saying that if the patient or caregiver refuses to sign the document, which even though the addendum signature requirement basically says that they are saying that they received it, but that they're not agreeing to the content, there are still patients that are refusing to sign. And so they are confirming that if you deliver it and put in that this is the date it was furnished, they are going to accept that, but it does still, the date furnished does have to be within the required time frame. But it is not going to be completely held against you if the patient refuses to sign the document. Just make sure that you note within the record that they did refuse, and make sure that you have documented timely that it was delivered. If anyone other than the patient or caregiver requests the addendum, you are not required to get a signature from them. For example, if a Medicare contractor requested the addendum, which they are allowed to do, including your Medicare MAC, you obviously have to provide it to them, but you're not required, of course, to get a signature from that contractor. Okay, this is continuing on with that 5-day language, and this recaps the 3 to 5 days as well. One thing that they did not do, this also talks about the fact that if the patient dies in the first 5 days of care, even if they had requested the addendum, you would not be required to provide it to them. And this is another example of the 3 days versus 72 hours, and some more detailed explanation on that issue. The next thing we're going to talk about is the COVID-19 waivers that they are proposing become a permanent change in hospice. And this is a really good change for us all. So if nothing else, you need to comment in a positive light that you agree that these items should be made permanent. And so hospice aid competencies, as we know during the current public health emergency, they are allowing that the competencies be done using a pseudo patient. They are also allowing if the patient or the aide is found to have a deficit in some portion of their competency, instead of having to do a full-blown competency evaluation, that you would need only to complete a competency evaluation of the specific deficient skill or related skills. And so having said that, both of those being allowed during the current waivers, they are going to, or they're proposing to make this a permanent change. So again, in a permanent change situation, you would be able to use pseudo patients in the hospice aid competency and simulations as you see there. And again, only having to do a competency evaluation when you have identified deficient skills, instead of having to do a full-blown competency evaluation just because you found one deficient skill. So there's going to be a transition of the way that you submit your HIS data coming very soon. We don't know how soon, but we do know it's going to happen. It's already happened in home health. In fact, it happened in home health in January of 2020. So home health has been using the iKey system for almost 1.5 years now. Hospice will be moving to this system. It's simply iKeys instead of keys. Instead of the quality improvement and evaluation system, a new internet quality improvement and evaluation system. And it is for real-time upgrades and greater security. Yes, we did move to it in home health in January of 2020. They have not announced the date of migration, but I will tell you that in home health, we did get, I'm pretty sure, a 6-month notice that we were being moved into the system. So we are expecting that hospices will receive at least a 90-day advance notice, if not 6 months. That's what we're hoping. So don't quote me that that's what's going to happen. In the hospice quality reporting aspect of this rule, there is so much information that we could not begin to get through it in detail today. But I am going to hit the highlights, and I have given you a lot of detail information within the slides and the PowerPoint. So hopefully that will help you again in picking out pieces and parts that you need to focus on depending on your role within the hospice, informing the comments to be provided to CMS. So as part of the hospice quality program changes, they are discussing the removal of the 7 hospice items, hospice measures that make up the HIS comprehensive assessment measure in the Care Compare website. They are going to publicly be available in the data catalog, but they will not be publicly displayed. To make these changes, removing the 7 HIS process measures as individual measures no earlier than May of 2022. So if it is finalized that they're going to remove them, it will not happen before May of 2022 update. So there are also hospices that do not report HIS data used for the HIS comprehensive assessment measure will not meet the requirements for compliance with the hospice quality reporting program, which we already know, and we're going to talk a little bit more about the HIS submissions requirements in just a few moments. CMS is proposing a new measure to the hospice quality reporting called the Hospice Care Index. Now, I'm being told that this is or can be a pretty big deal. So hopefully those of you who are involved in the hospice quality reporting portion or quality monitoring portion of your hospice, pay really close attention to this information and make sure that if you have concerns, you do comment. There will be 10 indicators that are used in determining the hospice's overall care index. And you see the 10 items listed on the screen that they will be using to compose this hospice care index. The next screen talks a little bit about how the scoring is going to work. You're awarded 10 points for meeting each criterion for each of the 10 indicators. The sum of the points earned from meeting that criteria for each indicator results in the hospice score with 10 as the highest possible score. So they'll look at each of the indicators that we saw on the previous screen, give you a score of up to 10, and your overall hospice care index could be as high as 10. CMS will revise the report to include claims-based measure scores, including agency and national rates through the CASPER and replacement system. So the reporting that's done through those systems with HIS data, et cetera, will be used. This measure, as the other change, will be publicly reported no earlier than May of 2022 if it is finalized. This is a scoring example of how this hospice care index indicator would work. And so it gives you for each of the 10 items, the numerator, denominator in the example, the score, the national average score, the rank for that hospice in the national rank percentile ranking, index earned point criteria, the points earned yes or no, and then the points awarded for each one, again with a maximum hospice care index total score of 10. And not only are they talking or proposing that they make the calculation, they're saying that this will be publicly displayed. And so we are pretty confident that this is likely going to happen unless there is a huge uproar in the industry. And if it does happen, it's going to be pretty revealing in not a great way to some hospices that haven't paid a lot of attention to their quality reporting measures. But I think that every hospice should be getting into these 10 particular items that they're going to use in this hospice care index, and see where you would fall basically in that calculation today. The addition of claims-based measures are going to be looked at or implemented fully. The hospice visits in the last days of life measure is going to be publicly reported. And the HIS information that it came from or is going to come from will be from February 16th of 2021 through February 29th of 2024. And they're no longer going to use the hospice measure that was in place before. Hospice visits within, I can't remember exactly what that acronym stands for, but this is going to replace it. So this next screen talks about the inclusion of the administrative data and correct technical errors identified in the 2016 and 2019 wage indexes. So they're looking at making some changes to some of the errors that they found there. This screen looks at the actual technical corrections to identify those errors. We're not going to go through each one of them, but they're going to look at, and the ones that they're going to remove are going to be based on one or more of the following factors that you see on that screen. The next item is the HOPE update. So the HOPE tool is a tool that's intended to basically become a closer to a full comprehensive assessment of the patient. It is a tool that will be used to assess patients' conditions in real time based on interactions with the patient. It is going to be replacing the HIS that you currently utilize. They started out with this tool a few years ago. I can't remember the acronym that was used for the tool before, but they had to change it because it sounded too much like something else they were doing. But that one was scratched anyway. It was put into demonstration, and actually some hospices began using it, and then they scratched it and basically started over. So they now are using or now have gotten to the point with the HOPE tool that they have put out just in the last couple of weeks a call for hospices that want to volunteer to begin using the HOPE tool in demonstration form. Once they have done the testing and feel like they have a feasible assessment instrument to be used, they will have to propose implementation of the HOPE tool in future rulemaking, but the testing will have to be complete. So they haven't even made the selections as to which hospices will participate in that yet. So we are quite a ways away. I don't anticipate that we would see a proposed rule for this any sooner than this time in 2023 and probably 2024, depending on how well the testing goes and how quickly they can do an analysis on the testing that they're doing, because again, the testing hasn't even started yet. So this next screen talks about the CAHPS star ratings that they are going to begin publicly reporting. They would, if they do, publicly report the CAHPS score results on the Care Compare site or a successor website no sooner than fiscal year 2022. The hospice survey star ratings will be similar to the CAHPS star ratings that are currently displayed for hospitals and home health agencies. ranging from 1 to 5 stars, and the stars will be calculated based on top box scores for each of the 8 CAHPS hospice survey measures. One of the quality submission requirements, as you know, for the hospice quality reporting program includes the CAP surveys, and now they are going to be publicly reporting the results, assuming that this gets finalized. So to calculate a summary or overall star rating by averaging the star ratings across the 8 measures with a weight of 0.5% for rating of the hospice and willingness to recommend the hospice, and a weight of 1 for each of the other measures. So that basically just gives you some insight if you're used to looking at how they calculate stars and the star ratings for home health. It is very similar, at least I understand that it's very similar. You must have a minimum of 75 completed surveys in order for them to assign a star rating. So if you're a very, very, very small hospice, and you might not even have to be a very small hospice, if you have a low percentage of patients that actually, or decedents that actually respond to your surveys, then you might not even be included in the star rating. Some would think that's good, some would think that's bad. Because if people start truly looking at it and measuring you based on your star rating of the hospice experience survey, you're going to want, to have a number out there. But as of right now, you would have to have a minimum of 75 completed within the time frame that they're calculating the stars in order for you to have a star rating at all. And they would not publicly report this any sooner than fiscal year 2022, which is a bonus, right? So the quality dating reporting requirements, this one is huge. And so please understand that if you have ever been hit by this quality reporting percentage calculation, you really need to be commenting and explaining, what happened or what occurred and how that impacted you all. But the reality is right now, the regulation is that if you appropriately report and submit data in the hospice quality reporting program, you're good to go with the same rates that everyone else has. But if you do not meet the requirements, you are currently receiving a 2% decrease in payment on the following year's reimbursement. So if you failed in 2020, in 2021, you would see a 2% reduction in payment. This is the scary part, and this is why this is such a big deal. If you do not meet the reporting requirements beginning in fiscal year 2024, you will see a reduction of 4% to your payments, not just 2%. And so there is 2 different things that go into this calculation. The first of the calculations is that you are compliant with your hospice CAHPS survey reporting. And of course, you can get an exemption from that if you are small enough. You have to make sure, of course, that you respond within a certain amount of time. The other piece to this calculation is the submission of HIS data and the timeliness of the HIS data. The HIS data, you have to have submitted at least 90% of them within the 30 days required following the completion of the HIS, the date it was completed. So those 2 things in combination are where we are with that. And then this is interesting. 90% of all required HIS records must be submitted and accepted within that 30-day submission, which is what I was just talking about. To comply, you are also required to collect the data monthly using the CAHPS hospice survey. Hospices comply by utilizing a CMS vendor, of course, for the CAHPS. Most hospices that fail to meet the quality reporting requirements do so because they miss the 90% threshold. I'm going to tell you that over the last few years, I have had a few phone calls from hospices that are like, Melinda, we received this letter and we don't understand what it means. Can you look at this? And they'll send it to me, and that's what the letter is. And in fact, they discover that they did not meet the 90% threshold. And I'm telling you, from knowing these hospices, I would have never in a million years guessed that they did not meet the 90% threshold or didn't have things in place to do that. So if you don't look at yours, you need to look at yours, and you need to ensure that you have processes in place that will prohibit you from being hit by that adjustment in the future. These next few screens, we're not going to look at the details of. They are screens that talk about the public health emergency and the fact that the data for certain quarters are not going to be allowed. So these are the screens. This particular chart is the one that you want to look at if you're trying to figure out the release that just occurred February of 2021 of the quality reporting data. What periods of care that reflected. And as you see, the third and fourth quarter, the second and third, first and second, I'm gonna get it out in a minute. Okay. There we go. So I'm finally straight in my head at what this thing is saying. So in the second column, it tells you what it normally would have displayed. In the third column on the far right, it tells you what is actually going to be displayed as a result of the public health emergency. And as you see at the bottom of the screen, the first and second quarters of 2020 are not going to be reported at all. So that's what I was trying to get to. Got lost in that for a second. Sorry about that. Okay, this is the same thing for the CAPS reporting, and this on the far right gives you exactly how the data is going to be reported and which quarters of data will be reflected. Again, first and second quarter of 2020 not being included. So this next information is the calculation of publicly reporting claims-based data, the hospice or care index that we talked about a few minutes ago, and an example of the dates that will be used for that, the 90-day runout, which we're not going to get into the details of, but if you get into all that kind of stuff, the detail information is there for you. That continues talking about the timeframes of the new claim-based measures that we referenced earlier, and this one as well. So again, if you get into all the details of that, you have plenty of data there to take you through that. This next screen is talking about the health equity gap. In recognition of persistent health disparities and the importance of closing the health equity gap, CMS is requesting information on expanding several related programs to making the reporting of health disparities based on social risk factors, race, ethnicity, and more comprehensive and actionable for providers and patients. There is more detailed information regarding this issue in the proposed rule, and they are truly looking for our feedback as to things that could be done to help close this gap. And it is a topic that we all should be concerned about and considering input on. This screen just basically gives you a recap of each of the things that we've talked about today. I have given you a lot more detail in the screens than I typically do because this rule was so overwhelming. I wanted to be able to give you a clip of each of the things that were of significant importance so that you would have it to reference and go back to when you need to. So that brings us to the conclusion of my portion of the presentation, and I will turn it over.
All right. Thank you so much, Melinda, for sharing your expertise and education with us. really such valuable information to help everyone plan ahead for what's to come. So I hope everyone can take this and continue to plan for the rest of the year.
You're so right. You're
Yes.
so right. It's great information. Thanks so much.
Yes. So just for a few minutes, as mentioned earlier, my name is Lindsay Cobb and I'm the Director of Product Marketing for Waystar. And what I wanted to take a few minutes to discuss was how Waystar and KanTime have partnered together to ensure that you have the right partners and the right technology in place to make your rev cycle processes simple and easy so you can focus on the things that need your attention, such as new rules and regulations as discussed today. Next slide. All right. Do you all still see a poll? There we go. All right, perfect. So Waystar and KanTime have been partners since 2014. We've grown tremendously together over the past 7 years. And along with that comes connectivity to over 5,000 payers, allowing you to consolidate your claim submission processes for both government and commercial payers through one source. And then we can apply our extensive claim edits and scrubs to help you achieve that 98.5% or better first pass clean claim rate, where your claims reach the payers faster, cleaner, and ultimately allowing you to get paid faster. And we're also supported by a solid technology infrastructure that ensures you can not only process, or that we can not only process 2 billion transactions annually, as you see here, but that we can continue to grow together with that foundation, and that we're scalable for that growth, and that you can have the confidence as you grow that we can support that. And Waystar brings many years of experience, as does KanTime, so we can collaboratively provide you the right knowledge and direction on where we can go together in the future. And we're really excited to take that journey with you. Next slide. So Waystar thinks holistically when providing solutions and services, and that is what is represented here. We want to help solve challenges across the revenue cycle to ultimately help you get paid faster and more accurately. In every category listed here, we've done something that is completely differentiated from what is available in the market. So take denial management, for example. Our inspiration was simple. About 3 years ago, everyone in the industry told us they had a denial management product, and maybe they did, and they were right that they had one. And there was probably a work queuing system that prioritized denials in some way through a workflow. But as we spent time with customers, we would notice that almost 100% of the time, everyone who had a denials product also had people on the phone, people logging into payer websites, gathering faxes, doing a lot of manual processes outside of their platform with no real analytics and visibility into the denial process as a whole. So we created a solution that would solve for both the articulated and inarticulated needs that existed. And then we created our denial and appeal management solution. We've recently grouped the 20 plus Waystar products into these 5 core categories across the revenue cycle, as you see here. And it becomes this all-in-one platform that has a lot of capabilities that keep you from having to worry about downtimes and upgrades. It's very easy to use. You can process 24/7 with seamless integration, and we have integration with KanTime that we'll talk about in a moment. And we also have, analytics that can truly help you predict and take action on things that we expect to happen so you can be as proactive as possible. Next slide. So before diving into this in a bit more detail, we're going to launch one final poll now that you've heard a little bit about our partnership with KanTime and what Waystar does. So Greg, if you're going to launch that one, we can do that real quick. And I'll just continue reviewing the slide. Once that pops up, feel free to take a moment and click and answer. Taking from the previous slide view and breaking it down into a solution level view, which is not encompassing of every product we offer. However, there are solutions these are the solutions that we would recommend for clients in your space to be as successful as possible with your revenue cycle processes. And you'll notice that we offer several integrations directly within KanTime's platform, those being what I refer to as your core EDI transactions, or the foundation, if you will. So claims, remits, and eligibility. And then everything else here helps support your efforts to receive payments from payers and patients alike. So you'll notice that we have integrations with eligibility, claims, and remits. And again, all of these supporting ancillary services, I will call them for today, really help support and drive your revenue cycle success. And so if I'm not going to get into too much detail today, I know that you've had a lot of information thrown your way today. So certainly if you have questions, we're happy to answer those or set up some additional time with you at a later date. Next slide. And then lastly, I'm going to wrap up with how Waystar takes our solutions and delivers value differently. We know that while products are a big part of what we do, it's not the only component to being a leading partner for our clients. It truly requires us to think and act in terms of our clients' experience and their needs. And we understand that when it comes to your rev cycle solutions, features and functionality don't mean much if you can't get the support you need when you need it, which is why we provide in-house client support for our solutions so you can resolve questions or issues quickly and really get back to business. You know, building a simplified and unified workflow demands that versatile technology and a partner who can grow with your business. And that's why we pride ourselves on our innovative and collaborative approach to serving our clients. Our partnership with KanTime allows us to uniquely provide advanced solutions, boosting productivity and cash flow so you can focus on what matters most, and that's your patients and their care. And with that, I'm going to turn it back over to Greg and Kristen to help close us out.
All righty. Well, I think great presentation all around. Melinda, in particular, I don't know how you covered that information in that short a period of time. Clearly, you know what you're talking about. You did mention how important the cost report is. I've reached out to our support group during the presentation and verified that KanTime does indeed track all of the costs and financial data required for the cost report associated to what services are provided within KanTime. Of course, there's other things like ambulance and stuff like that, but it does allow you to export it to Excel and then make any additions that are necessary so you can accurately submit that very important report. Lindsay, thank you so much for your participation here as well today. Just a little add-on. Many folks on here know that Waystar didn't used to have the direct DDE access. They now do with their acquisition of eSolutions. So they are able to provide probably more services than you're even aware of. We are completely out of time, so we won't be able to address any Q&A today, but I do want to thank you all so much for your time today. And we will be reaching out with a PowerPoint deck and answers to any questions that you've presented. That concludes our webinar for today. Thank you again and have a terrific day.